Hi guys, Dr. Dillard here. It is Monday, it's week 10, the last week of lectures we're starting. It's the spring of 2021. Let's finish up talking about prostate cancer. So it is the second leading cause, just remembering from last time we talked about it. It's the second leading cause of death in American men, only behind heart disease. At the time the diagnosis is made, about 50% of these cancers have already metastasized, so not good. About 65% of the time, the cancer starts in the peripheral zone, which is good in a way because this is the zone that is palpable during prostate examination. All right, let's see, 7% of the time it's in the central zone. 15% of the time it's in the transitional zone. That's the one that usually causes dysuric symptoms where you have trouble urinating. It can be very confusing because that's benign prostatic hyperplasia usually causes that symptom. A little of the pathology. Here's an overhead view, an S to I view. Here's the rectum. Here's the prostate right here. There's the left and right lobe. And we can see a capsule around that surrounds the prostate. It's not as robust anteriorly, but here is the capsule. If it penetrates through this capsule, it's not good. Remember, it starts in this zone here. The peripheral zone would be right back here. And you can see in the corners we have just a nest of lymph vessels, blood vessels, and nerves here. So it can get metastasized very easily if it gets into this region. So poor prognosis if it does metastasize. It can also invade, if it gets through the prostatic capsule, it can also invade the seminal vesicles. That's a terrible prognosis. It metastasizes usually to liver, lungs, and spine when that occurs. So it's a really bad prognosis. There are two pre-existing conditions, precancerous conditions. One's called atypical small acinar proliferation, and the other is PIN, prostatic interepithelial neoplasia. I'm not going to talk any more about that. Some fun facts. Usually the form of cancer is an adenocarcinoma, so it's a gland-filled tumor. The peripheral zone prostate cancer can sometimes invade the bladder trigone, and so even with peripheral zone cancer you can still get dysuria. That's important to understand because it obstructs. Remember, the trigone of the bladder is right here, and this is split open, but there would be a little hole right here for the start of the pre-prosthetic urethra actually lives there. That's where my pointer is in right now, and the cancer tumor can block that, so you can get dysuria from spread of peripheral zone prostate cancer. Denovillez fascia, Denovillez fascia, it's a hard one to say. That's a strong barrier posteriorly. Again, it's interesting too because it's a one-way barrier. And do I have a picture of it? Yeah, it's right here. It's this extra cancer right here, or extra. In addition to this, they should have made these different colors, but the prostatic capsule is right there, and then it's extra thick Denovillez fascia, and it's really pretty strong. It resists metastasis. It keeps cancer going out, but it's terrible about letting cancer go in, which is kind of interesting. So if you do get rectal cancer, cancer growing in this region, it can invade into the prostate gland or metastasize into the prostate gland because of that strange property of that membrane. Lymphadenopathy is a problem if it gets out of the capsule. It will next get into the lymph system. Specifically, it usually, in this order, it usually shows up in these nodes. The obturator node, the external iliac node, and the internal iliac node. Right? And it can get into secondary nodes as well. Common iliac, presacral, para-aortic are the other secondary nodes. Interestingly enough, it tends to spare the superficial nodes. So that's weird. So are you going to pick this up on examination of the nodes? Because you know how to do an inguinal lymph node exam. Just run your fingers over in the inguinal ligament region and look for nodes swelling up. And no, it typically doesn't invade those. So again, it likes this external iliac node and the obturator node here and the internal iliac node, and these are the second nodes. But it tends to spare the ones that are palpable, all these superficial inguinal nodes and the superficial femoral nodes. So it's often not detected by exam. This is important. Where does it spread? And this is not a good thing. Chiropractors have to be very careful of this because you're going to x-ray a lot of lumbar spines during your career. And that actually is the number one target. It loves the axial skeleton, but in order again, the lumbar spine is the number one target of prostate cancer. In order, number 2 favorite target is the proximal femur. Number 3 is the pelvis. Number 4 is the thoracic spine. Then the sternum, and then we get out of the axial spine and go to the humerus. What kind of metastasis is it? Is it osteolytic or osteoblastic? It can be both, of course, but more commonly it's an osteoblastic type of metastatic lesion. So the bones look too white or radiopaque when you review them. It can involve long bones or the vertebrae, we said, and compression fractures of the vertebrae may be the first sign of its presence. If it blows out the vertebrae from extra bone formation, it could encroach into the vertebral canal and cause central spinal stenosis and all of its sequelae. What's the sequelae of compressing the thecal sac? Well, you get neurogenic intermittent claudication, NIC. So the patient can't walk for more than a couple blocks and his legs get really heavy and they may hurt. And if you sit down and bend forward, wait for 5-10 minutes, you can walk further before the same thing happens. You get radiating leg pain, low back pain. Cauda equina syndrome could happen, but it's probably rare. 45-year-old male comes into the clinic. He's had a prostatectomy 5 years ago for what they thought was benign prostatic hyperplasia, BPH. And you take an x-ray. What do you think? Ready for an adjustment? You can see the surgical staples for the removal of the prostate. What do you think? Oh, nice calcification of iliolumbar ligaments. L5 is transitional. Yeah, your eyes are drawn right to that white vertebrae. That's no good, right? That's a terrible sign. So that's osteoblastic activity from prostate cancer. Got it? Soft tissue. It can also affect the soft tissue. In fact, the favorite targets are the LLA, lungs, liver, and adrenal gland. So this can be a rare cause of Addison's disease, right? It can invade the adrenal cortex and wipe out the entire cortex, and you get no hormone release, and that's definition is primary Addison's disease. There are some genetics we should talk about a little bit. There are chromosomal rearrangements are usually the type of mutation that occurs and is associated with prostate cancer. Mutations of, and I don't expect you to know those numbers, just chromosomal mutations. For those of you who have to know everything, 8, 10, 11, 13, 16, 17, and 18. And the type of mutation is important because it can predict the outcome of the prostate cancer and predict the aggressiveness of that cancer. You can also look for tumor markers, one called ERG, erythroblast transformation specific related gene. ERG is a key regulator gene of tissue homeostasis and make sure that the cell dies on time, make sure it doesn't go through mitosis too rapidly. If it does, it can terminate that cell's existence. This marker is typically overexpressed in prostate cancer. And more specific about ERG, it's considered an oncogene because it watches the cell with regard to proliferation, spread, and apoptosis. It can't divide too much, and it can't stay alive too long, otherwise it'll be terminated by this gene. with regard to spread, somehow it knows that the cell's still attached to a basement membrane and hasn't lifted off. Remember, invasive cancer needs to separate from the basal membrane before it can invade into a lymph system. It's technically considered a transcription regulator. And trouble occurs when it gets inserted into a different chromosome where it's not supposed to be. And that's a translocation, right? That's when a chromosome gets put into a chromosome that it's not supposed to be in. And that mutation makes a protein, a mutated protein called the TMPRSS2 ERG. You don't need to know that, but it basically fails to do its job. It fails to regulate proliferation, apoptosis, and watch the basement membrane, as I've already said. Right, and yeah, these are cancer cells. If you get a ERG mutation and your cell becomes cancerous, the ERG isn't there to destroy it, so the cancer just runs wild. That's why that mutation is. The mutation in and of itself doesn't cause the cancer. It just means, all cells have these tumor suppressors. There's always tumor suppressors around. If you don't have this, there's no way to self-destruct the cell, and it just goes on. Another common mutation is the BRAX1 and 2 mutations, which I believe in 23andMe, the chromosome testing now that's out there, you can get the results of this, which is a good idea. So men who have a family history, sister, mom, grandma, who've had breast cancer or ovarian cancer, the men are at risk for prostate cancer, significant risk. So especially if you, it's even worse if your mom or even you have the BRAX1 or BRAX2 mutation in your genes, in your genome. It's just all your genes. All right. Clinical findings for prostate cancer. Well, there are usually no findings. That's the trouble with this. Early on, there's typically no findings. If it happens in the transitional zone, then you can get a dysuria, and maybe that's a good thing, and they can catch that. But it usually happens in the peripheral zone, and you won't get any symptoms unless the peripheral zone invades into the trigone of the bladder. So it can be, but if it does get into the transitional zone, it's tough to tell apart from BHP. So bottom line, it's tough. This is a tough cancer. Other symptoms during which it's compress the prostatic urethra or the trigone of the bladder are just exactly the same as BPH. Hesitancy, decreased flow of urine, decreased or sensation of incomplete emptying, double voiding, straining to urinate, post-void dribbling, painful ejaculation, urgency, frequent urination, nocturia. All the exact same ones for BPH. Examination findings in some way with prostate cancer. Well, maybe the digital rectal exam will be positive if you have one. I mean, guys don't like, it's kind of embarrassing. I'm telling you, it's no big deal. It takes literally 2 minutes, and not even that. I say it takes less than a minute. It'll save your life. But if your primary doc is good at finding it, he'll catch the cancer and save your life. So you could find a nodule or a very hard prostate as a sign of this. If the digital rectal exam is positive, you always order a biopsy of the prostate to see if it is cancer, which is done by ultrasound. So that's called a transrectal ultrasound with a transrectal biopsy. PSA is just ordered as part of your physical in guys once they get over 40 anyway. But order it again if you find a nodule. This is one that surprises. A lot of people miss this on exam. How can prostate cancer cause lymphedema? Here's a 34-year-old male with stage 4 prostate cancer, and it spread into the deep inguinal lymph nodes, and look what happened to his leg. Beaver dam, right? The lymph can't drain out of the lower extremity, and it's swelling up like crazy. If the prostate cancer breaks out of the capsule and it gets into the deep inguinal nodes and grows inside the nodes, it'll beaver dam those nodes, and you can't drain fluid out of your lower extremity. All right, so it backs up. Same with your testicle. Your testicles can swell up as well because of this. So it can create a lymphedema in the affected lower extremity or both sides, depending on what you have. You might get, this is advanced, but you might get post-renal azotemia. I think we've talked about that before, but that means that you have your dysuria is so bad that the beaver dam in the prostate or the beaver dam in the bladder is causing the beaver dam backup is going all the way into the kidneys and increasing the pressure, and so that's no good. The urine will back up into the kidneys and back up into the nephron and significantly raise the pressure, which will slow the GFR down. And that the bottom line is, if the pressure is increased within the kidney doesn't remove urea and nitrogen containing compounds from the blood very well, and your blood becomes rich in urea and nitrogen. And that is called azotemia. Anemia could be present from, it would have to be severe metastatic disease, but if it affected your all of your marrow-containing bones, you could start to get an anemia, because we know the bone marrow is responsible for making hematopoiesis. And so if you start having decreased hematopoiesis, then you could get an anemia. That's a terrible sign, by the way. Also, if it gets into the bone, your alkaline phosphatase levels will also be elevated. Other cancers can do that as well. Your PSA levels, let's look at those. And I'm not a big one with numbers, but I do want you to know these numbers. I guarantee you make a note card, guaranteed test question on these. Normal PSA levels are 4 nanograms per milliliter or less. If you have a level between 4 and 10%, there's a chance you might have prostate cancer. It's about a 25% positive predictive value, meaning 25% of men in this range will have prostate cancer. Once it gets over 10, I mean, now we're up at 60%, and there's a range on this. So it's still not positive. You get over 20, I mean, the higher you go up, the more likely it is you have cancer. There is the Thompson study we should talk about. Quick, published, it was a classic, old study, but classic. It was very well designed, and it demonstrated a direct relationship between the level of PSA and the chance of getting PSA cancer. That's where this came from. They noted, however, important to realize, they noted that occasionally men develop prostate cancer and the PSA levels were normal. So it's not perfect. There is a false negative rate on this test, but it's not that high. What about 5-alpha reductase inhibitors versus PSA? So many men with BPH, we talked about the epithelial type of BPH, they take 5-alpha reductase inhibitors, which work pretty good to shrink the prostate. The trouble with that is it artificially lowers PSA readings by up to 50%. So heaven forbid, if you got prostate cancer and BPH at the same time, and you're relying on those, you're relying on PSA levels, they might be skewed because of that medication. So you have to watch out if you're taking that medication. What do you do for it? What if you have prostate cancer? Very debatable what you do about it. We'll get into this right now, but you have to take into account these factors: the age and the life expectancy of the patient, the treatment morbidity, you know, how if it's an old person who doesn't really worry about sex too much versus a young person who sex is very important to them, because it can cause it will cause sterility, but it can cause a lack of sexual function as well, impotence, and what stage of the cancer it is. So the treatment options are androgen deprivation therapy, basically cut out testosterone. Radiation therapy is a big one. Cryotherapy, hyperthermia treatments, these are kind of fringe. Laser therapy, water balloon therapy. The big one is the radical prostatectomy. That's the gold standard, and we should talk about that. Radical prostatectomy, there's a bunch of AKs for it. It's a surgical procedure which basically takes out the cancerous prostate gland as well as the seminal vesicles, ties off the ties off the vas deferens, so you can't have babies anymore. And yep, that's the one that's typically used. You can use that to treat severe BPH as well, but it is the gold standard for prostate that's contained. That's, you biopsy the lymph nodes, and the lymph nodes are fine. There's no cancer that's gotten loose. It's when if the cancer's gotten loose, then you're radiation and chemotherapy, and you could probably still take the prostate out if you wanted, but it's the men who have contained prostate cancer which is controversial. That's the treatment. If it's already out, then you use this procedure to get it out, and then you do chemotherapy. There's two approaches: perineal incision versus a retropubic, suprapubic approach. That's not really that important. The major risks for prostatectomy are an injury to the internal urethral sphincter. I mean, that and external urethral sphincter, that holds your urine in your bladder. So if you damage those, you're going to be incontinent. You can't hold your urine. You don't have to worry about retrograde ejaculation because there's no more seminal vesicles, there's no more prostate, there's no more vas deferens. So that's kind of a moot point. The pudendal nerves are damaged in about 50%. I've seen up to 70%. So this is a problem. You got probably at least a 50% chance that you're going to be impotent. You'll still have the desire to have sex, but the plumbing won't work. Can't get an erection. And you will become sterile. Now there are some, they're trying to find ways to not be so, but that's not a radical prostatectomy. I mean, that's radical because it takes everything out, so you will become sterile. Lymphedema could occur as well, because if the lymph nodes have been filled with cancer, they have to be removed as well, and they're not very good at reconnecting those tubes. It was the same deal when we talked about breast cancer. So you can have lymphedema in your lower extremities. It can be painful as well. And you can get edema in the lower extremities and in the testicles as well, or in the scrotum. Bad omen. If the cancers went through the prostatic capsule and invaded the deep inguinal lymph nodes, it's not good. It's a bad omen. If the pathologist discovers any cancer-filled lymph nodes, that means the cancer has spread, and 85% chance that it's spread to distant locations. Sometimes the lymph nodes have trapped the cancer and it hasn't gotten out of the lymph nodes yet, but 85% chance the lymph nodes weren't able to hang on to it. Again, it loves the liver, lungs, and lumbar spine. LLL. Prognosis. So if at the time of surgery the cancer is confined to the prostate, the 10-year survival is 77%, kind of an average. If it's gotten out of the capsule and gotten into the lymph nodes, it drops to 40%. If it's gotten into the bone, the lungs, or the liver, it's much lower even. To cut or not to cut. So a prostate cancer that is contained, or a localized prostate cancer, there's some controversy on this. A big New England Journal of Medicine paper, of course, that's the #1 research journal, the most trusted in the world. 2017 paper looked at this, and they published the results of a study which looked at 730 men who had prostate cancer that was contained. The average PSA was 7.8 on them, and they were randomly assigned into a radical prostatectomy group or a watchful waiting group. And you would think, oh my gosh, the watchful waiting group is going to do terrible. But that wasn't the case, and they were followed for at least 12 years. A very good study. That's the Wilt study, 2017. So at the end of 12 years, and these same results held to the 20-year review. So at the end of 12 years, about 63-64% were dead out of this cohort. So if you look at the group breakdown, 61.3% of the radical prostatectomy group had died. Almost 67% of the watchful waiting group had died. So if you do the statistics on these two numbers, you come out with a p 0.06. So technically, to be significant, you have to be p.0 or p equals 0.05. So it was very close to being significant, but not quite there. So the authors should have said, and they didn't really, kind of disappointed me that they didn't say this, because they made it said that there's no statistical difference. So people would think, oh, I can just don't have to get radical prostatectomy. I don't think that's a good thing to say, because the research, it was very, very close to suggest that having a radical prostatectomy did save lives, but it didn't quite make significance. So if it was me, I would still get the radical prostatectomy. Radiation therapy is another common way to treat therapy. The problem is there is some research that shows the technologists aren't very good at hitting the target. Prostate it's not like skin cancer where it's on the outside and you can see it. They have to aim the radiation beam just right, and in one study only 30% of the patients, or 30% of the patients, they missed the target. So that's not good. If you combine radiation therapy with androgen deprivation therapy, you get a better result. And these are treatments other than the radical prostatectomy. And androgen deprivation therapy, it's testosterone. Cancer cells need testosterone to grow. So if you cut off testosterone, and you don't have to cut off their testicles, you can use a luteinizing hormone luteinizing hormone releasing hormone agonists to do the job, or there's androgen inhibitors and anti-androgens. There's several medications you can take that will shut off your testosterone. What are the side effects of radiation therapy? It can scar up the prostatic urethra if they do hit the target, and you can end up with dysuria and even hematuria, bleeding and kind of a scarring up of the tube. So you might have to have a TURP after the dust settles from this. Bowel urgency and frequency, rectal bleeding, tenesmus are others, and sexual side effects are other common effects from radiation. And not to mention, with regard to radiation, you're bombing someone with radiation. How many of these people are going to get cancer in 10 years just from the radiation? So it's about double, they think. The risk of rectal and bladder cancer doubles starting at 10 years after the radiation. All right, that will do it. See y'all later.